Good evening. I'm Dr. Paul Theerman. I'm director of the Academy Library and the Center for the History of Medicine and Public Health. On behalf of my co-organizer, Michele Calvo, I warmly welcome you to our discussion, Then and Now, Drug Policy and Harm Reduction Services. We're very glad you decided to join us as we explore this important topic. Before I turn to our panelists, I wanted to give you a short introduction to the Academy and to its Then and Now series, and to the Academy's early history of drug investigation. The New York Academy of Medicine was founded in 1847, 175 years ago. Today, NYAM is happy to take on the mantle of champions for health equity, tackling the barriers that prevent everyone from living a healthy life. The Academy Library dates from the very beginning of NYAM. We have since grown into one of the most significant collections in the history of medicine and public health in the country. We invite you to connect with us both digitally and in person. As part of our 175th anniversary celebrations, the Academy Library is taking the lead in organizing events around the theme Then and Now, using the insights of history to shed light on issues in public health where the Academy has done and is continuing to do significant work. In these events, we seek to pair historians and their distinctive take on events with policymakers, researchers, and people with lived experience. Tonight is the second such Then and Now event on drug policy and harm reduction services. Two more events will take place in the fall on libraries and medicine and on healthy aging, and we hope that you will join us then. The Academy has long engaged with the challenges of drugs in society. In the 19th century, the Academy decried the widespread use of patent medicines of doubtful health and often of harm, and censured fellows involved with them. In the early 20th century, through its Committee on Public Health Relations, the Academy weighed in on regulating harmful drugs and cosmetics. The best known example of the Academy's work, however, is the LaGuardia Report of 1944, where the Mayor's Commission on Marijuana Use demonstrated that the widespread fear or even panic around using marijuana was greatly overblown. The Academy continued to emphasize that drug addiction was a treatable condition, and during 1995 and 1996, the Academy's Committee on Medicine in Society looked at the concept of harm reduction, recommending policy changes that were, for that time, cutting edge. Our panelists will bring the story current, sharing their experiences and insights, and I look forward to hearing what they have to say. You can share your perspectives too, as well as your questions, in the chat section of Zoom, which we'll turn to in the last part of the program. I also acknowledge the support of the Sarah Welt Fund, the Liliana Souter Lecture Fund, and the John K. Lattimore Fund in mounting this program. I now pass the podium to Michele Calvo, Program Officer in Community Programs and Policy Solutions at the New York Academy of Medicine. She has been NYAM's lead for drug policy and criminal legal system reform, collaborating with advocates for change, and she's been instrumental in the development of tonight's event.
Thank you, Paul, for that kind introduction. Good evening, everyone. I'm really excited to be here with you tonight. As Paul mentioned, so NYAM became involved in harm reduction in the late 1990s, and this was around the time when the first legal syringe exchanges began operating in New York and around the country. In 2001, NYAM developed a comprehensive plan for syringe exchange in New York City and went on to conduct a number of studies that over the years have provided guidance to drug treatment providers, healthcare providers, policymakers, and others, including most recently and directly relevant to our event tonight, the supervised injection feasibility study, which we conducted in partnership with the Peer Network of New York and others. NYAM has also been a partner in policy change with drug policy advocates, providing public health evidence for policy change in New York. And some of these policy areas included the Rockefeller drug law reforms in 2009, expansion of naloxone, the legalization of medical cannabis, the decriminalization of syringes, expansion of syringe access, and expansion of medication-assisted treatment in jails and prisons. We always try to follow the lead of people with lived experience and those providing care to people who use drugs on the ground, some of whom are on this panel tonight. And with that, I'd like to introduce our speakers very briefly. I won't go through everyone's bios since we have them listed on the event site for you to read. So on our panel tonight, we're thrilled to welcome Terrell Jones, who is Community Engagement Manager at New York Harm Reduction Educators, Senior Co-Chair of the Peer Network of New York, and longtime friend and partner of mine and NYAM's. We're also thrilled to welcome Sam Rivera, who's Executive Director of On Point NYC, otherwise known as the leader of the nation's first overdose prevention center. And if we were all in the room together, I'd hope we all be cheering and clapping and going crazy because it's an incredible accomplishment. And I'd like to welcome Maia Szalavitz, who's a prolific journalist, author, and also an advocate in her own right. Her recent book, Undoing Drugs, The Untold Story of Harm Reduction and the Future of Addiction, is the first history of the harm reduction movement. And finally, I'd like to welcome our historian and interviewer for this evening, Samuel Kelton Roberts. He's a renowned historian of addiction and more broadly, medicine, history, public health, science, and technology. Dr. Roberts is Associate Professor of History and Socio-Medical Sciences at Columbia University. And I'll pass it to you now, Dr. Roberts.
Thank you so much, Michelle. Thank you, Paul. Thank you to the Academy, and thank you, most importantly, to all the members of our audience today. I've been looking forward to this meeting for a long time. As I think, speaking for the other panelists, if I may, I think all of us have been. This is a much needed and necessary conversation, and I, for one, am certainly very happy to join you all today and to be part of this discussion. I think it's easy to imagine that some of the impetus behind putting this together was a historic event that we saw last month, which was, of course, the White House National Drug Control Strategy, the first one which explicitly advocated harm reduction. And these drug control strategies have been released every year since the 1980s, I believe. So we're looking at roughly 40 years or so. And this is the first one. And within a movement, by the way, which is almost 40 years itself, harm reduction, that is. So this was certainly, as many of us have commented, a historic moment. Harm reduction in this document mentions syringe, among other things, syringe service programs, low barrier treatment courts, et cetera, et cetera. This, of course, begs a bit of a question, which is, what is this thing that we call harm reduction? If you look around, some standard definitions will offer more or less 5 elements of it. Definitions may differ across continents, across regions, across organizations, and individuals working in the field. And I hope we can talk a bit about that. But in most of these, you might find 5 baseline presets. One of which, or the first of which, is a pragmatic view of certain behaviors which bring about harm. In the area of intoxicants, what we call drugs, this is a recognition that as long as there has been human history, there has always been a realm of non-medically used intoxicants or psychotropic drugs, psychoeffective drugs, and that trying to eradicate use, ban use, entirely criminalize use is probably not going to be effective. And certainly in the case of the 20th and 21st century, against good public health. A second precept would be the maximization, augmentation of individual autonomy and dignity. This is particularly important because it's not, from what I can tell, something that really gets emphasized in the drug control strategy, particularly the dignity part. While assertions as much might not have been entirely common in decriminalization movements going back to the 50s and 60s. Most self-described harm reductionists from the 80s and forward and today will emphasize the preservation and augmentation of an individual's autonomy and dignity as a foundational principle to the work. You can't do this work without wanting, holding it dear and sacrosanct that part of that work is to maintain the dignity and autonomy of the person in question. This is what it means to have a people-centered approach, by the way. A third element that we often find is a hierarchy of needs and a priority of immediate goals. This is also crucially important because so much of our treatment establishment, leaving aside the criminal justice establishment, our treatment establishment, our regimes of medicine, historically have focused on one thing, which is getting the patient, quote unquote, off of drugs. That might be the only goal, in fact. A hierarchy of needs approach emphasizes that for many people, perhaps using in a more safe manner, decreasing use, or even ceasing use, for those who choose, is part of a larger basket of goals which they wish to accomplish. And a good harm reduction approach is going to take that into consideration and consult first in a people-centered approach. Consult first with the person in the individual in question and ask them, what's the hierarchy of needs? What do you want to do first, second, third, fourth, fifth, et cetera, et cetera. This is what we mean when we talk about meeting the person where they are, for example. Another precept which I find particularly interesting is harm reduction as an alternative to the criminalization / medicalization binary. We tend to have thought over the past century or more of drug use as being either a criminal justice issue, which is to say a moral issue, or a medical one. You know, people are sick and they need medical help. And from my understanding and my work in this field and studying the field, there are many people who actually would resist either one of those, that we need not necessarily think about subjecting individuals to the criminal justice system and its abuses, or to the often coercive nature of medicine itself. This is not to say that harm reduction is at all anti-medicine. Not at all. Some of the most ardent pro-vaccination people that I've known have been people who work in harm reduction because they see the ravages, for example, of COVID-19. We're not talking about anti-medicine, but there's a difference between that and, say, being very careful about medicalization and what that implies for subjecting people to the authority of a doctor. We see this, for example, in many courts where if people don't successfully go through a treatment regime, they can be put back in jail, for example. There we see medicalization, criminalization, actually working hand in hand. And a good harm reduction approach, as I've understood it, as someone who studied this as a historian, is that a certain amount of resistance to that binary is warranted. And then finally, there's a maximization of non-coercive and appropriate intervention options and as they are appropriate to each individual. This is to say, going on those previous four, that whatever a harm reductionist does, whatever a harm reduction organization does, whatever a harm reduction policy plans to implement, it must be non-coercive. To say that, we're going to offer you treatment, but then if you don't do it, we're going to put you in jail isn't a whole lot better than just putting somebody in jail anyway. That a good harm reduction approach, as I've come to understand, and I hope to hear more from our panelists, is that first and foremost, well, maybe not first and foremost is the dignity and autonomy, but part of that is that what we do should not be coercive. And this is elementally important. So, of course, in our nation's history of drug policy, we have not followed these precepts. I think that's patently clear from over a century and a quarter of drug policy. In fact, it's been our generally Manichaean view of drug use, which has reigned, seeing people who use drugs as either, evil, or morally bankrupt, and then people who abstain as being good and virtuous. We've not been able to think our way into anything better than that. Some of this is our kind of cultural heritage, the Victorian era Protestant work ethic. We valorize people who not work to live, but people who live to work. As a virtue itself, self-sacrifice and self-denial of all pleasures, sexual, substance related or anything, has been part of that. And then also there's an ideology to that as well. It is a good way to stigmatize people who don't fall into that rubric. I might also venture, though, that part of our failure to think in terms that we are now hailing as historic, or as this historic developments of the last month or so, is really political. Drug policy has not ceased the harms of drug use at all. 50 years of the war on drugs, over a century of prohibitionism has not done that. But that begs the question that why is it still there? And I am not alone among historians who have argued that quite often it has served a purpose in terms of policing and surveilling the politically unempowered. Women are more likely to bear the stigma than men. The poor are more likely to bear the stigma and the onus of punishment than the wealthy. And I probably don't need to remind most of the people in this audience, but just in case I do, virtually every moral panic we've had historically around drug use in this country has been racialized in one way or the other, be it anti-opium laws and stigma in the late 19th and early 20th century, which is traced to anti-Chinese racism. During that same period, the first cocaine scares, particularly in the South, were tied to anti-Black racism, quite often used as a rationale for lynching Black people, to just say they were cocaine users. Our first marijuana laws, brought about by the vigorous advocacy of Harry Anslinger of the Federal Bureau of Narcotics, was based largely on a racist campaign attributing marijuana use to Mexicans and Mexican Americans. Heroin in the 50s, later largely associated with Black and Latino communities, crack cocaine in the 80s and 90s. It goes on and on. In fact, I think the current attribution of the new opioid, which is no longer new, epidemic, the way we've thought about it as being largely white, I think is the exception that proves the rule, in fact, that this new, kinder and gentler approach to drug policy is largely because of this new demography, which I think we will also explore is not that new. So then the question is, to sum up, and which I want to pose to my panelists, our panelists, is what then is an appropriate harm reduction stance? Do we simply go with the 5 precepts that I've mentioned, which are good ones, I think? I didn't make them up, by the way. I think if you look around, these are the maxims that are held by many of our major organizations. But I think if you ask people working within those organizations, they might also say that perhaps we should take it further. Harm reduction might need to think, as much as it does about reducing the quote unquote harms of drug use, maybe we should think about the harms, societal harms, the harms that that society has inflicted upon us that have nothing to do with the drugs at all. You know, the social, economic incapacitation of, so many people vis-a-vis a drug sentence, the stigma attached to that, all of those things. So the question is, as the title of the panel also states, the past, the present, but also the future of harm reduction. It is fortunate that today, on Monday, the 16th of May, thanks to the New York Academy of Medicine, we have these 3 wonderful panelists, Sam Rivera, Terrell Jones, and Maia Szalavitz. So welcome to all 3 of you. Glad to join you. How are you all doing today?
Good, thanks.
Fantastic, great to see you all again. I think I've seen some of you in person recently. Maia, you and I have not seen each other, I think, since before the pandemic, but good to see you in whichever way I can. I want to start with the, let's put one just straight over the plate. What is harm reduction to you all? And I think I want to start with Sam and Terrell first, as the phrase goes, as frontline workers in doing this work. Sam, Terrell, what is, in your mind, harm reduction?
Oh, go ahead, Sam.
Yeah, hey everyone, pleasure to be here. For me, harm reduction, I mean, you touched on a number of very important points, especially about looking at, for me, when I look at harm reduction, it's harm within harm within harm within harm, right? There are layers of harm. I don't agree that there's a drug war. I believe there's a war on drugs. I mean, there's not a war on drugs, there's a war on drug users. That's the way I look at it. There's not a war on drugs. I could barely get an avocado into this country from Puerto Rico, but we're getting tons and tons of drugs into this country, allowing them to go into Black and brown communities and then holding them accountable for the same drugs that are being allowed in. So, harm reduction in what we do, there should be other layers of what it is. Harm reduction within this portion of the work we do. So harm reduction in our world is really mostly about humanizing or dehumanizing, situation and population. And for us, it's really about keeping folks alive, knowing that, especially now with fentanyl and the impact of all the overdoses we're facing, harm reduction is also an acknowledgement of people. It's an acknowledgement that of drug users and accepting them as humans and respecting them and loving them in that way. So yeah, it's interesting. We own the term harm reduction in that way, but what you said before, Sam, around expanding that into other elements of this world, right? When we go to the court systems and they created drug courts, they looked at it as a form of harm reduction. It's sad that most people going into treatment are going to treatment through from being mandated. So yeah, harm reduction for me is really, I look at harm reduction when you say, even when I hear the term, I smile, because I think of the most amazing staff on the planet, loving folks who most of the times don't know what love feels like. People that have been dehumanized, people who are judged on a level that's almost impossible to come out of. So when I hear it, I think about being innovative, being open in ways that are beyond amazing, and at the core of it, it's still about keeping folks alive so that they will have an opportunity to stay with us as they belong, and understand that they are folks who primarily those who use, primarily, for the most part, are using to self-medicate traumatic pain, traumatic experiences, and mental health conditions. And so harm reduction allows that space for folks to be humanized and accepted in a very loving way. It's a long answer to a short question.
Thank you for it. Terrell, I interviewed you for a podcast, I think it was about 5 years ago, about 2017, wasn't it?
Yes.
And you said something to me that has always stuck with me. You said, and I think this is an exact quote, maybe you could correct me if I'm wrong. You said, harm reduction saved my life. And for those in the audience who are not familiar with Terrell Jones's work, he is widely recognized as one of the most dynamic workers in this field, certainly here in the city of New York and known nationally as well. So when he says that, there's a lot of weight behind that. Terrell, what does that mean to you? What is harm reduction to you? Like what when you're out there, when you're doing your frontline work, when you're doing outreach, and before this conversation started, you talked about some of the challenges that you and your team face. I don't imagine that you're keeping like a 5 elements in your mind at all time. Like it's something probably deeper than that. What do you think? What are you doing when you're out there doing the work of harm reduction?
Thank you for allowing me to be here today. You said harm reduction saved my life. Harm reduction brought me back to humanity. I get very emotional when I talk about what harm reduction has done for me. You know what I'm saying? The love, the compassion, the care that was given to a person who used drugs, a person who was ostracized by his own community because of being a drug user who used crack at this time when this epidemic in our community was at its worst. When you sat there and watched the news, everything is about how people using crack and how they're destroying the community, this and that, you know what I'm saying? And to be caught up in that because of my drug use and how my community treated me because of what they were seeing on TV and what was being portrayed. People sat by and walked, spit on me, kicked me, called me every name in the book. When it came to harm reduction, they called me my name, they called me Terrell. They opened their arms to me. They showed me that I was capable of being loved. I was capable of being treated as a human being. And it changed my life. Harm reduction means that reducing harm in all aspects of a person's life, not just drug use.
That's something I want to get to eventually as well, because the ONDCP, which is the Office of National Drug Control Policy, their statement, the strategy statement, they're concerned mainly with drugs, but they seem in their vision of harm reduction is very much limited to drugs. Whereas it sounds like you're saying that this is being a person-centered approach. We're thinking about more than that. And organizations such as On Point, New York Harm Reduction Educators, and Washington Heights Corner Project are involved in doing much more than just the kind of basics of harm reduction, as I understand it. Now, Sam and Terrell, maybe you could just briefly tell us a bit of some of the services that you all offer.
ED?
Go ahead, brother, talk about it.
Okay, so I think one of the most important services to me that really helped change my life was holistic therapy. The acupuncture, acupressure, the Reiki, you know what I'm saying, the going into a room and being able to meditate, to give full body acupressure and feel my body changing, to feel my body going to another level. You know what I'm saying? To my ancestors, as I was told, to specialized groups, where what was keeping me out there in the street was me not addressing my trauma and going into a safe space where I could talk about that. As many people know, I was raped as a child. And when I talked about those issues in other places, I was the victim. What did you do to entice a person to do this to you? And I was like, wow, 6-year-old kid, you know what I'm saying? But all the services that we have, the case management, you know what I'm saying? These services that are being provided are coming from people with love, shared life experience, understanding. And everybody doesn't have that shared life experience in there, but they have the compassion and the love and understanding to what harm reduction is and to embrace it to its fullest. You want to take it there from there, Sam?
Well, I want to bring Maia into this as well, because Maia's written this fantastic book. Actually, I hope you don't mind, Maia, I'm going to do a little plug for you here. You can give me my share of your revenue, your royalties later on. This is Undoing Drugs, the Untold Story of Harm Reduction and the Future of Addiction. Fantastic book. I'm a fan of Maia's since Unbroken Brain that was about, 5 years ago or so, Maia? But in any case, also fantastic read. I highly recommend this book. Maia, I want to ask you, this is over 300 something pages, but if you could, in a nutshell, tell us how did we get to last month? Because harm reduction in your telling it's an underground endeavor. We have people just making a way where there's no way, a lot of improvisation, a lot of risk, a lot of people getting arrested, a lot of people, dedicating their lives to the principle of ensuring the well-being and dignity and lives of the people around them. And with government really not giving, I'm going to keep my language clean here, but not really caring, shall we say. And then, fast forward some, 35 years later, it's now White House strategy. What's the trajectory there?
Right. So, all right, I'm going to try to keep this as short as possible. So, harm reduction is about prioritizing stopping harm rather than prioritizing stopping people from getting high. And what that means is humanizing people and treating them as human beings. And it is astonishing that this takes a revolution, but it does. Because we have just used drugs as an excuse for racism and all kinds of ways of just humiliating and attacking people. And so when somebody comes into a needle exchange or a overdose prevention site, they are just met with love and welcome, whereas the rest of the world is literally spitting on them. And so where did this come from? So obviously, the idea of reducing harm is as old as medicine, Hippocratic Oath, blah, blah, blah. But the movement as such begins in Liverpool in 1987, where there is an HIV, they're at high risk of HIV. There's an outbreak in Edinburgh, which is not far away. What Edinburgh had just done was just really like close this methadone program, crack down on needles, and basically spread the virus so much that half their young people who were injecting were already positive. So Liverpool said, okay, we're not going to do that. And they created this idea of, we're going to welcome people, we're going to prescribe heroin, we're going to prescribe cocaine, we're going to teach wound care, we are going to meet people where they are. And when they started doing this, they started seeing amazing things, people's lives turning around, just like the power of love. And so they wanted to spread this around the world, and they came over here, and lots of people picked up that message. And lots of people, of course, were already doing that right here, starting syringe exchanges, trying to fight HIV, realizing that this is a much bigger threat, and realizing that, wait a minute, why do we care about stopping euphoria? Why don't we care about stopping hurting? And, so this message sort of takes time to grow, because the whole thing of the drug war was getting high is the worst thing ever. We have to stop these people from doing this. We don't care if it kills them, because that will be good as an example to children. It will send the right message. And now we're like, the heck with that message. We want people to live. We want people to be okay. And that is a more morally powerful message if you can get it into people's heads. And that's basically what the movement did, with people, throughout the country, working really hard, setting up syringe service programs, setting up naloxone distribution. This comes directly out of harm reduction. This guy, Dan Big, goes around handing out naloxone, the overdose antidote. And, before that, you could only get it in a hospital or an ambulance. And he's like, look, this stuff is like, it doesn't hurt you. If you use it by mistake on somebody who has a heart attack, well, it's not going to solve the heart attack, but it's not going to make it worse. So why isn't this over the counter? It should be over the counter now. So this whole movement comes together and realizes that harm is the thing we need to stop, not euphoria. And it slowly begins to make inroads. And then, I hate to say it, but when the problem gets framed as white, suddenly people become more open to saving lives rather than having people die as examples. And that is just awful, but at least we can use it to move towards kinder policy for everyone. And I just want to say, I was really moved by what Terrell said, because harm reduction also saved my life personally. And, it is an astonishing thing when somebody stops lecturing you and starts saying, what do you need? What happened to you? You matter. And, these seem like little things, but if you're constantly getting kicked around and constantly hating yourself, and somebody believes in you, that has just such an enormous power. And so, this movement grows, and people start, doing things like Housing First. One of the first organizations that did that, Housing Works in New York, Keith Kyler, who was an active drug user all through his time being one of the leaders of that organization. And he, knew that if you give people a house, it is much more likely that they are going to become healthier than if you require them to become abstinent first. So we get this whole thing, and eventually it gets to the White House and it moves into the mainstream. I mean, I think the COVID pandemic also sort of helped that in a weird way, because everybody began to realize that, no, we're going to not stop everybody from socializing. It's like not possible. People are going to take risks. We got to reduce harm. And so the concept became sort of more understood. And I think, we still have a long way to go, because, as you say, the Biden administration kind of is limiting it to, it's naloxone, it's needle exchange, it's overdose prevention sites. No, it's a much bigger thing. And what it does by saying that harm matters more is that it turns drug policy against itself, because if harm is what counts, then the harm of prohibition starts counting, and the harm of the criminal prosecution system starts counting, and the harms we do to people to try to help them starts counting against it. And then we can start, where we should, which is human being to human being.
It's what you were just saying there about policies and kind of the structural elements, if you look at the ONDCP statement, the phrase harm reduction shows up in impressively numerous, a lot of times is what I'm trying to say. But I would venture to say that second place is transnational criminal organizations, or TCOs. There's a lot of emphasis on drug interdiction, basically just continuing to build up the criminal justice industrial complex. And so one has to wonder, can you have a robust harm reduction while you also have all this money being funneled into doing the same thing that we've been doing all this time? That's very much a rhetorical question. So I don't want to just throw that out there. Who was that? Was that you, Terrell? Says it possible?
That's me. That's
I think you went out on the same wavelength there. But Sam, that rhetorical question was actually a lead into a real question that I want to direct towards you about criminal justice. You and I had a discussion a while ago about it's colloquially known as the crack house statute.
Yeah.
And you were, and I wasn't aware of this, to be honest, and I'm embarrassed to say so, but I'm going to admit it in front of our public today. I wasn't quite aware until you talked to me about this, the extent to which this is a barrier to good harm reduction. Can you tell us, and we have a question in the chat, and by the way, I encourage our audience to start putting their questions in. I think now we can probably more or less official enter into the Q&A. So this question is in part from Shirley Gerard, who asks, what kind of state policies can we put in place for harm reduction? But I also want to begin that answer perhaps with, tell us about some of the criminal justice statutes that are blocking good harm reduction, please.
Yeah, I first wanted to go back a little bit. I think it's really good, I don't want to say great, that ONDCP is talking about harm reduction in the White House. All this stuff is coming out. Let's just be very clear. And you said it, so I wrote it down, so I'm erasing it. What else is included in that language is about building up. Let's just keep arresting folks as well. It doesn't work. It's a contradiction. Let's fry food and throw water in it. Well, it's really intentional. And I'm worried about us celebrating the term harm reduction being said a few times or a number of times or what have you, when we have the crack house statute, especially when we're also falling short. They're talking about harm reduction on syringe exchange when we need to be talking about safe consumption sites. So I want us to be careful about falling into this oppression celebration that we're taught to do and saying, yeah, this is great, this is happening. I think it's good. It's not great. We need great, right? I think it's good that it's happening, but it's falling short still again. And we need to continuously, the door is cracked open, let's kick it open, right? We have to kick it open. The crack house statute was the president. I'll be happy to share the video. Maybe somebody could find it. This is when he had hair and he was a lot younger. He's very proudly says, I created this thing, the president. And I sent numerous messages his way that he's blessed that we live in America, where you get to redeem yourself, where you get a second chance, the Second Chance Act. So we're going to give him a second chance to get rid of the crack house statute. A couple things about crack house. It's called crack house because the minute you make cocaine crack, it becomes a black and brown and poor white issue. It's not the cocaine statute because then you'd have to close most of lower Manhattan, right? So it's not called that.
We could call it the Wall Street. We could call it the Wall Street corner office statute.
The Wall Street.
Right?
There you go. Right. We would have to. So this is all intentional, and so I just worry that it's really good to acknowledge these changes, but it's not enough. And I've sent these messages to both Biden and Raul Gupta. It's important for them to take true ownership of what's happening. We're not as dumb as you think we were. We're clearly not as dumb as you think we are, right? Because that's what they're doing. They believe, I'll just say this and it's enough. I'll remind everyone, they also created this harm reduction, the first harm reduction funding on a federal level through SAMHSA. The minute white supremacists got upset and said they're spending $30 million on crack pipes, the same government, the same SAMHSA, the same ONDCP, and the same White House froze and then said to those who were applying for that grant, you cannot buy crack pipes. Mm-hmm. That was their fear. That quickly, they jumped in and said, you cannot buy crack pipes, which is completely crazy because you could buy harm reduction supplies, which includes crack pipes. So within that discussion, we are getting ahead of this game they've been playing with us for many years. And that's what I'm happy about. What I'm really excited about is you can't, this game is over. We're way ahead of you and we're not going to let it go. What we did for many years in harm reduction, and I go back to the days of ACT UP and all that, is we fought because we had to fight. And I mean, sometimes physically, literally fight. And what I did this time coming into harm reduction, I said, I want us to be more of a loving warrior. I'm a warrior. Fighting is always an option. It's always there, but I want to use it last, right? And so what they're dealing with now with us is they do these things where years ago we would fight and lose our minds and curse and chain ourselves to doors. And we're not doing that, right? Now we're tweeting and saying unacceptable. So I really want people, and I see some people are posting this great information, to learn what's happening in the background. Let's not go partying in the street and set off fireworks yet. I believe it'll happen. I'm asking the Rahul Gupta and Biden to wake up and just say it's fine now, where we are operating a health intervention that keeps people alive. 100% of our participants, 100% have been to treatment and detox, 100%. So that argument's off the table now, right? That's where everybody goes. Send them to detox and treatment. And we can talk about detox and treatment successes as well, but that'll take another conversation. But I just want to really put that out there. Last thing I'll say about policy is in New York State, we are moving forward. And I hope one of our folks can share this, this bill. We are moving forward. In a way, New York's badass approach is, all right, we're not going to wait for the government. We'll create the answer here. So the city created the answer by allowing us to open these 2 sites. And now the state is creating the response. The next portion of the answer is to fund those sites without worrying about whether the federal government agrees or not. What we know is they've been quiet, and by DOJ being quiet is good, right? I'm not worried about DOJ approving this. They could stay quiet, I'm fine with that. We need to crack our statute gun, and we need to be able to have funding, especially when I've spoken to HRSA, SAMHSA, New York State, New York City Health Departments, ready to fund us today if they allowed it. So.
Great. I want to go back to, and we've got a lot of questions coming in here, so I'm going to try to field these as best I can in the remaining more or less 15 minutes that we have left. I want to go back to, and I'm sure I'm butchering her last name, Shirley Gerard. I'm definitely mispronouncing her name, but her question was about what policies could states or what do we need to have in place to help with harm reduction efforts? And that seems like where you were going with that, Sam. So maybe you could take another 60 seconds to flesh a little bit more out for us. And then Maia and Terrell, if you also want to join in on that as well, please do.
Yeah, there are, and there are, I'm sure there are many people in the audience smarter than me regarding these policy work. But the reality is there are all of these loopholes where the state can step in while the federal government plays around, and they can get us funded. And that's a fact. We've seen it. We've seen it with marijuana, right? So we're learning all these techniques, which is really good for us. So really on a state level, it's about the state legislator making the decision to fund local harm reduction organizations to provide these services. And the reality is, what we see when you allow an organization, a harm reduction organization, to create a safe consumption site is an immediate reduction in overdose deaths, right? We're coming up on 300 overdose intervention, 300, and we only open at the end of December, basically end of November, basically December 1st.
This is On Point. You're the organization that you lead. 300.
Yeah.
And what was the date on which you opened again?
November 30th, we opened. The city had hoped to open 3 years ago, 3.5, almost 4 years ago, the city hoped to open 4 sites and have those 4 sites intervene in 130 overdoses. We have 2 sites coming up on 300 overdoses, and it's only been since November 30th. So a health intervention that keeps people alive is real. We're watching the numbers decrease. That's just one organization with 2 sites. Wait until we open all the other safe consumption sites. Last thing I'll say about that's huge around talking to folks about their pocket and their taxpayer dollars. One of my favorite things, the stuff that people like to argue about, is during those, and in fact, almost 19,000 utilizations of our site, just the overdose prevention centers, the safe consumption sites, we've called the ambulance 5 times. 5 times. On every other overdose in the street, the ambulance come, the police come, it costs thousands and thousands of taxpayer dollars to get that person, take them to the ER, et cetera, et cetera, et cetera. Police time, police report, ambulance time, ambulance report, fire department, et cetera. It's a great life-saving intervention that America was 30 years late to, but we're here and it's important to expand.
And I would just want to say, in terms of state policy, decriminalize possession, defelonize it at the minimum, but decriminalize it, because there is absolutely zero argument for locking people up for possession. There is no good that comes from it. It gives people a criminal record. Incarceration takes a year off your life for every year in. According to a recent study from New York State, it increases suicide, HIV, hepatitis C, COVID, overdose. So, you know, there's absolutely zero reason to spend hundreds of millions of dollars repeatedly locking up and arresting the same people over and over and over. It does not, you know, if you look at the state arrest rates versus state drug use and overdose death rate, there is zero correlation. It does. If it were working, you should see more arrests, less drug use, less death. You do not see that. It's probably an inverse correlation. But the point is that that this is one policy that we could immediately eliminate without any harm, which would reduce harm, and we would also free up a lot of money that we could use for harm reduction, things like overdose prevention centers, treatment. You know, good, decent, supportive, empathetic treatment, not treatment that breaks people down, and all kinds of other services that would actually reduce harm and promote health.
Maia, you just said, if anything, there's an inverse correlation. I think what you were.
I'm wrong. Yes, I mean there should. Right.
No. I wasn't trying to correct you. I was just asking for clarification. Were you saying that the more someone's arrested, the more that, you know, the colloquial rap sheet gets longer and longer, the more socially and economically immobilized they are. It's harder to get a job, harder to get housing, all those other things. And then at a certain point you say, you know, why recover? Like, you know, like there's no incentive for me to do anything else. Is that what you're saying? There's an inverse.
Yeah. I mean, and
okay.
there certainly are. If you look at the more you get locked up, the more likely you are to die of overdose or suicide or any of these other things. It is not correlated. Again, if it were working, more arrests should be less drug use, which would be an inverse correlation. But the point is just that it is a harmful, useless intervention that does absolutely nothing to promote health.
Yeah, but it does something to. I agree 100%. What it does is it keeps Black and brown communities where we are. We plead out. If you ever spend a day at Rikers, you're going to plead out the minute you get to them sitting you down and scaring you and telling you you're going to do 50 years, which now you have a felony on your record. And there goes with, then that goes to what Maia's referring to. Right now, you're going into that deep dive. So I think in some ways, I totally agree, but I think in some ways that's also the intent of the folks in power, is to keep us down in that way. So I think, you know, Maia's example is excellent, because if you really want a health outcome, and you know, you're wrong, you're doing it poorly. But if you want to keep Black and brown people where we are and where we've been, then you're doing.
That's an excellent way to do it. Then. Right.
Yeah, I mean, if you look at it like they said, I'm going to take me an example of somebody who went through the criminal justice system, and because of the racist policies and racism in the criminal justice system, I went to prison. But the 2 young white boys that had the same charges as me, they went home. They went home to Staten Island, upstate, to their families. Where Terrell had a controlled substance 3rd-degree sale, I did 4.5 to 9 years in prison. And if I decided to go to trial, it was going to be 9.5 to 18 years. But let's look at the policies that we have in place. Some are good, but some of them are racist policies that are in place that are only for Black and brown people. White people won't get to serve the same time in jail as a Black or Hispanic person would. And I am a product of that.
I wanted to ask, thank you, Terrell, because there was another question. There was a couple questions about that I wanted to pose to the group, but also specifically to you. One was about I guess for I'm trying to find a better way to or a way to phrase this. You work intimately in your outreach work with people who desperately need the services that you and your street team provide. You know them in ways that, you know, policymakers wouldn't know them, physicians wouldn't know them, a lot, you know, just a lot of folks, right? You were there literally on the street. I've brought my classes to come meet with you and your team, and we all learned a lot. The general public tends to think of drug users as though that's, you know, that's all they do all day. Just I'm a drug user. That's it. Like on the W-9 form, they write in occupation drug use or whatever. But these are actually whole human beings. What are some of the ranges? What's the range of things that people are facing, along with, you know, whatever issues they're dealing with a substance use disorder? Like how does harm reduction address the whole person there? And just in a few moments, because I'm trying to, these questions, for every one we answer, we get like another 2 or 3 in. So I want to get these as many as we can. What's the whole person there?
I think when it comes to harm reduction, we try to address the personal side of a person first. Who you are, why you here, what can you accomplish in your life. We look at you as a person, and we try to build that person up to whoever you feel that you should be. Making the individual feel comfortable inside themselves.
So specifically though, like just to kind of give our audience, because we have a number of physicians here, and some of the questions that are coming in are going to this question that I'm asking you. Do you have people, for example, saying, you know, I'm estranged from my family, for example? People would say, I think I really need some mental health counseling, and God knows physical health.
People are saying those things, and
Yeah.
they need those assistants out there in the street. Why would you want to go into a place where you're going to be stigmatized? That people don't really understand you. How many people are doing this because of the capitalism behind it? The money that they're getting into their pockets, instead of coming out in a genuine, loving, caring way to help a person. When an individual could go into the hospital because they have a broken leg, but they have a track mark on their arm, and the doctors want to go on the side and talk about the track marks on your arm instead of talking about, you know, what you're there for. Why would I want to go see a doctor? Why would I want to go sit there to see a psychiatrist when you're not going to help me at all? You know what I'm saying? Well, you need to stop using drugs. And drugs is not the damn problem. It could be incest, rape, or anything else, you know what I'm saying? Address the issue that is affecting the person, not what you want to address and what society wants to address.
That example about the broken leg actually is kind of spot on to a question that I'm, again, probably going to butcher your name, and I apologize in advance. Tom Daslala, maybe Daslala, asks us, meaning you, the panelists, there is a lot of research on how MDs, meaning physicians, in training lose compassion for people using drugs as they go through residency and fellowship. What are a few tangible things we can do differently to better support people using drugs in emergency rooms, in hospital and outpatient settings? And Terrell, that example gets towards it. Yeah. Is any of you on this panel aware of how this is being addressed in medical schools?
Yeah. I
for example,
say something there, because I am very hopeful about the young doctors in this area, at least the ones that I hear from, because they get it. They are not like calling people who show up in the emergency rooms, you know, I'm not going to say it because it is a curse word, but there is a name for them that is subhuman piece of that doctors historically have called people, you know. So, and this is a active live problem right now. Pain patients right now are getting, like, somebody shows up with sickle cell and they're having a stroke and they get accused of being overdosing, and then they don't get the treatment that they need in time. So this is a horrible, horrible thing that's going on right now. Part of the issue is that doctors are supposed to turn away drug seekers. And that, you know, people who use drugs are sort of natural enemies of physicians because we're the people that can lose you your license. And so a lot of that hostility comes from the legal system saying you must police these people. And so doctors really need to stand up for that. The other thing I think that is really important is to have people with personal experience speak to young doctors about these things. And somebody like Terrell just talking about what it's like to show up in the emergency room and just be treated as though you're not a human being and that your pain doesn't matter and that you couldn't possibly have pain because people with addiction don't feel pain, or Black people don't, it's just so. But I think really, once you hear those stories of people, it humanizes them and it starts to address that compassion fatigue or, whatever develops over time. But I also think that like a lot of the younger generation is really throwing away this whole idea that addiction isn't something we deal with. We just send these people away to go and take a moral inventory. And so, being engaged with prescribing Suboxone, seeing people get better also is really helpful, I think.
Quickly, I don't normally do this, but I'm gonna say this and Sam know it. This man came and changed the way we worked. We allow now Mount Sinai interns to come on outreach with us. To see and hear the plight that individuals that gonna come to their office, what they're going through firsthand, in the streets, under the bridges. You wanna come walk me and give an individual syringe. You wanna come walk me and give an individual condom. You wanna come walk me and watch the abscess of everything this individual has on their body and then listen to their story firsthand. We do that today.
Thank you. I think Tom, and I apologize if I mispronounced your last name, but I think you got some good answers there. If you want to follow up, can we recommend that Tom get in touch with On Point or New York harm reduction educators, and maybe they can bring some of their colleagues and maybe some of their training. I don't know if Tom works in medical education, but it sounds like you all are doing that work. Is that correct? Sam, I think you're muted, so.
Yes, we have a lot of opportunities for young doctors, residents to come in. A lot of it has been, we've seen the interaction has increased since we opened our safe consumption site. That's fine. Like, I don't get caught up necessarily in what motivates people. Just like when we opened and people said, what's the mayor's angle? Didn't matter to me. We're opening, right? That's what really matters. So I think, as Maia talked about as well, we're having young doctors coming from a very different place who are excited about this. I've met some young doctors that have blown my mind. But so getting them to meet our folks early on and understand that they are not, that drug use is something they do, is not who they are. It's not who they are. You were getting at this before. It's a part of who they are. Their mothers and sisters and brothers and fathers and uncles. We also know that when any institution, any kind of system works with a woman, you're usually working with a family now, and children. I'm not saying that men don't participate in that, but it's very different the minute you involve women. So when I watch it with women as well, and that disconnect is very scary. So having young doctors have access to what we want to do, Terrell and the team take them out. They go back and tell other doctors, you have to check this out. The other thing I'll say is, when this becomes part of a field in the medical world, or it's really discussed in that way in the medical world, then what we will get is our physicians who want to work in this work. I talk about my mom being an ER nurse in the Lower East Side in the 70s, and I'm watching her work with addicts, with users and doing wound care. And I would say, Mom, why do you do that? Like, that person, I was a kid, forgive me, please. That person doesn't care about themselves. And she goes, it's my job to care about them until they're ready, right? So what I would really like to see as well are physicians who want to work in this, right? We've been finding for years, and I see it's changing as well, that physicians end up in the ER as almost a punishment, not as a good thing, right? So what we're doing as much as possible is preventing the ER from becoming the place they seek medical care, right? And the biggest one for us are our nurses. We have nurses on staff, our own nurses, but we know nurses are the ones that interact the most. And, you know, I'm a little biased. My mom's the greatest woman on the planet. She was a nurse for 40 years. But we have nurses at our job like Sin and other folks who are amazing. But really having that level of interaction, and for folks who want to, as a medical provider, work with our people is where we want to get as well.
Fantastic. Thank you so much. I think we have basically hit our mark. But I want to thank you for this opportunity to talk with all of you. I'm a fan of all of you, and to have you all in the same, even if it's a virtual room, is like a dream come true. It's been fantastic to talk to all of you. I think I speak for the audience in thanking Sam Rivera, Terrell Jones, Maia Szalavitz, and the New York Academy of Medicine for joining us on this lovely Monday afternoon. Take care, all of you, and to everyone in our audience, thank you so much for joining us. And look at the NYAM website for future engagements and programming. Night.
Thanks so much.
Thank you. Good night, everyone.
Thank you.
Night.
Good night.